with pelvic pain issues, the typical treatment was either sex therapists or medical professionals. There's been an integrated shift in the last 10 to 15 years, and evidence has shown a multidisciplinary approach is actually the most beneficial for the client and most effective. And so this includes physical therapy, a medical intervention, as well as psychological intervention. And then from the psychological intervention, I think psychiatry also is really helpful. And that's sort of my own experience. And I think that if there's a woman who's having any sort of pelvic pain or anorgasmia, if she has a difficult time tapping into her own resources as a result of mood disorders or something that can be supported through psychiatric referral or medications, that might be something that you'll want to bring in too. But keep in mind that, for instance, antidepressants can have some antidepressants can have a negative effect on sex drive and libido and orgasm as well. So that way you're kind of in connection with the doctors too in doing this multidisciplinary approach. Okay, so there's been support for physical therapy in regards to pelvic pain. And what typically happens is the physical therapist will check out just the flexibility of the client, see if there's any places in particular that she holds tension. A lot of times that's in the hip flexors, in the legs, and in the back, because these muscles, the PC muscles, sort of connect all of those. And simply doing hip stretches can help open up the muscles, relax the muscles, bring more oxygen flow in, and which will help with the vaginismus.
Does the physical therapist do that, or they teach the client what to do?
They'll teach the client. They also do that in the session. So she'll have her do certain exercises and stretches to loosen it up. And then what's really helpful to have a physical therapist on board with the work that you're doing is that she can actually do a vaginal exam and use her fingers to teach how to be able to do a proper Kegel. As therapists, it's obviously something that we can't do. We can only do so much with words. So to be able to have somebody actually help the women feel what it feels like to clench at 100% and then at 50% and then release to 0, that helps the women get a lot more in touch with their body and have a lot more awareness.
Yeah. It's sometimes the same treatment for urinary incontinence.
Mm-hmm.
Yeah, I had that done.
Oh yeah, so you're aware. You know it's I bet.
UCLA,
Oh okay.
physical therapy.
Oh okay. Was it with Cindy Graham?
Yeah.
Yeah, she's excellent too. That's another one for UCLA.
Who?
And
Cindy
she used
Graham.
some machine, I forget what it was, some machine.
Oh,
Yeah,
did she?
GRAHAM?
Yes. Mm-hmm.
She was very good.
Yeah, she's fantastic. Her bedside manner. I mean, they all have really great bedside manner, but Cindy in particular is very, very warm. And I bet from your experience that if somebody were to just tell you, "Oh, do this," versus show you,
And so you
it
can
made a
feel
difference.
it and
Yeah.
have someone you can talk to and ask questions.
Mm-hmm. And making sure too, like, am I doing this right? And they
Right.
can give the feedback of no, a little bit less or a little bit more, or even just simply talking to you, I've noticed that your muscles have released. A lot of women have a difficult time going in and having this quite intimate experience with another person, typically a woman. It's very it's clinical, but then it's also in a very personal area. And a lot of people don't really have that understanding. And so being able to help support them through the discomfort that they might have by talking about it, helping support them go to the physical therapist and even prep for that.
And I had an older client who actually was more comfortable going to the physical therapist because it was a medical model versus actually self-examination. That was just more traumatic for her, very much scarier for her as well too.
Yeah, right. And that that's why it can be so helpful to have that integrated model rather than just saying go home, use these dilators, or do this exam yourself. And it's good to help guide their treatment. So they'll do the Kegel exercises, and then the dilators, basically they are like clinical or medical looking dildos essentially, and they have different sizes. So there's a small size that's, I don't know, maybe a little bit smaller, maybe around the size of my index finger, and then they go up to larger size, which is supposed to reflect the average size of a penis. or a sex toy, and they help the women kind of create a system where they can insert the dilator, do certain Kegel exercises and relaxation breathing techniques with the dilator inside. And the idea is to disassociate something inside the vagina equals pain. So that's the big point of having vaginal dilators is for women with pain and anorgasmia is to, again, separate that idea. So something inside the vagina does not equal sex. Yeah.
Can you elaborate on the relaxation exercises? What those look like?
Sure. So it'll be, in regards to physical therapy, it'll be having the dilators inside, contracting the vaginal muscles, and then releasing. So, and then even a breath before, like breathing, doing some sort of guided meditation before even using the dilators. Then using the dilators with guided meditation or with breathing and sort of relaxing the muscles. And then afterwards, using some sort of guided meditation or progressive body relaxation in order to ease out any tension that they might have experienced.